In the first vlog, we discussed the normal physiological changes in the liver function tests or the liver parameters. Then in the second vlog, we discussed the first case history of hyperemesis gravidarum. And in the last vlog, we discussed the second case history of intrahepatic cholestasis of pregnancy. In both these case histories, we learned that the hyperemesis gravidarum, by and large, it occurs in the first trimester. And the intrahepatic cholestasis of pregnancy, it appears in the second or third trimester, and it vanishes after the delivery. We learned the criteria for hyperemesis gravidarum and for the intrahepatic cholestasis of pregnancy. For the hyperemesis gravidarum, we learned that the criteria is intractable vomiting associated with dehydration, electrolyte imbalance, lab findings of starvation, that is ketonuria, and more than 5% of the body weight as compared to the pre-pregnancy weight. And in the intrahepatic cholestasis of pregnancy, we learned there is pruritus, followed by the liver enzymes elevations and bile acids elevation more than 10. We learned that if the bile acids is more than 40, it means it is severe intrahepatic cholestasis of pregnancy. And then we also learned that we need to follow up these patients by doing regular bile acid level monitoring. If it remains less than 100, we plan the delivery at 36 to 39 weeks. But if it's more than 100, it crosses the 100, then pregnancy at 36 weeks must be planned. And then we learned what are the risk factors for intrahepatic cholestasis of pregnancy and risk factors for hyperemesis gravidarum. We learned how to treat them and what's their impact on the pregnancy, on the mother, as well as on the fetus. Today, we shall discuss the third case history of the series and see what's the diagnosis, what is the criteria of diagnosis of this condition, what is its impact on pregnancy, on the mother and the fetus. So let's go to the case history. Today is the case history number 3 in our discussion on pregnancy-specific liver diseases. This is a lady, 34 years old, multipara, 25 weeks pregnant lady who was previously controlled hypertensive, and she presented with headache and pedal edema. No history of fits. So it's a lady who was having hypertension prior to pregnancy, and that was controlled. So 34 years old, multipara, 25 weeks pregnant lady, previously controlled hypertensive, now presented with headache and pedal edema. No history of fits. On examination, blood pressure is 165 by 115 millimeter, pedal edema positive. So her blood pressure is this with pedal edema. The liver function tests: bilirubin 1.3, mildly raised, ALT 127 raised, AST 90, PTA, PDT increased. So these are the liver function tests. The CBC hemoglobin 9.5 gram, TLC 11,000, platelets 132,000. Other labs, urea 55, creat 1.8, urinary protein double plus, electrolytes normal. So this is the picture. Question is, what is the most probable diagnosis? And of course, how will you treat her? Again, I show you 34 weeks old, multipara, 25 weeks gestation, previously controlled hypertension, no BP is high, pedal edema is there, raised LFTs, CBC low, HB, TLC high, upper limit, other labs, urea high, creat mildly high, urinary protein double plus. Please write down the possible most probable diagnosis so to see if we are correct. Diagnosis here is pre-eclampsia and eclampsia. There are no fits, so pre-eclampsia. And again, first we discussed the hyperemesis gravidarum, and we saw that it happens in the first trimester. Then the intrahepatic cholestasis of pregnancy, the second case history, we saw it happens, it starts in second to third trimester. And now this is the pre-eclampsia and of course related eclampsia. There are no fits or patient is having pre-eclampsia. So few words about the pre-eclampsia. We know that hypertension in pregnancy is defined as a blood pressure of greater than 140/90 on at least 2 occasions. So a pregnant lady who has BP of 140/90 on 2 occasions, we declare this as hypertension, pregnancy-associated hypertension. Hypertension-related liver diseases in pregnancy include pre-eclampsia, eclampsia, HELLP syndrome, and hepatic, haematoma, rupture, and infarction. So these 4 are the hypertension-related liver diseases: pre-eclampsia, eclampsia, HELLP syndrome, and hepatic, haematoma, rupture, and infarction. What should be the diagnostic criteria? We know the pre-eclampsia develops in 3 to 5% of all pregnancies. So the diagnostic criteria for pre-eclampsia is new onset, 140/90, or worsening hypertension more than 140/90 after 20 weeks gestation associated with proteinuria of more than 300 milligram per day. So the criteria is that there is new onset hypertension more than 140/90, or the previously hypertension which was controlled, it has gone out of control, and this happens after 20 weeks of gestation, and there is proteinuria of more than 300 milligram per day. What is the diagnostic criteria for eclampsia? That was for pre-eclampsia. Presence of pre-eclampsia associated with development of generalized seizures. When the seizure develops, the pre-eclampsia changes into eclampsia. Eclampsia develops in 1.9% of women with pre-eclampsia and 3.2% of women with severe pre-eclampsia. Pre-eclampsia is a multisystem disorder where placental ischemia leads to endothelial dysfunction and coagulation activation. Pregnant women with systolic blood pressure of more than 160 or diastolic blood pressure of more than 110 and are evidence of organ involvement are considered to have pre-eclampsia with severe features. So when the BP is more than 160 systolic or more than 110 diastolic, or there is end organ or organ involvement, we define this as severe preeclampsia. There is hepatic involvement in 20 to 30% of cases of preeclampsia. Not all patients with eclampsia has hepatic involvement, but 20 to 30% of these develop hepatic involvement. And this is thought to be secondary to vasoconstriction of hepatic vascular bed. The presence of seizures with no other explanation differentiate eclampsia from preeclampsia. What are the risk factors for preeclampsia? These are classified as high risk factors and moderate risk factors. The high risk factors are previous pregnancy with preeclampsia, multiple gestations, renal disease, autoimmune disease, and diabetes, and chronic hypertension. So these are the high risk factors for preeclampsia. Previous pregnancy with preeclampsia, multiple gestations, renal disease, autoimmune disease, diabetes, and chronic hypertension. And the moderate risk factors are nulliparity, advanced maternal age, obesity, family history of preeclampsia. Why this is important? It's important when you give them low-dose aspirin. The low-dose aspirin reduces development of preeclampsia and fetal growth retardation restriction. This should be initiated between 12 and 28 weeks gestation in women with any high risk factors or more than one moderate risk factors. So, what we discuss these risk factors, if a lady without any signs of preeclampsia, if they have got any one of these high risk, if she had a previous pregnancy with preeclampsia, if there are multiple gestations, if she has got renal disease, or if she has got autoimmune disease, or if she is diabetic, she has got chronic hypertension, then we need to start them on low-dose aspirin. But if there are more than two risk factors, either nulliparity or advanced age, obesity, or family history of preeclampsia, then we will start these patients on low-dose aspirin, and this will be initiated between 12 and 28 weeks of gestation. What about the antenatal corticosteroids? These should be considered in women who are less than 34 weeks gestation to promote fetal lung maturity. All patients should receive intravenous magnesium sulfate to prevent seizures. This was prophylactic, and this is the treatment and cerebral changes during the intrapartum and postpartum period. Timing of delivery, what about this? Delivery beyond 37 weeks gestation if no severe features, and prompt delivery is warranted at any gestational age if there is severe hypertension and organ dysfunction or concerns about fetal status. And we discussed what was that criteria. This is the one diagram showing the etiology and effect, like immunological factors, genetic factors, environmental and social factors. They leads to decreased uterine placental blood flow, ischemia, high placental oxidative stress, then imbalance of anti and pro angiogenic factors, endothelial dysfunction leading to PIGF stimulation, placental dysfunction, and FIT1, and it leads to the maternal complication as well as to the fetal complications. Maternal complications, circulation. On the circulation, there may be hypertension, cardiac remodeling, in the kidney, proteinuria, AKI, in the CNS, headaches, hyperreflexia, visual disturbances, eclampsia, fits. Then the liver, there may be right upper quadrant pain, HELLP syndrome, subcapsular hematoma, and the hepatic infarct or rupture. And in the blood, there may be HELLP syndrome and there may be DIC. While on the fetus, the IUGR and the intrauterine growth retardation, the oligohydramnias, the placental eruption, the premature birth, and the fetal or infant death. So this is the whole spectrum and it has got its specific etiology, its pathophysiology, impact on the fetus, and impact on the mother. So I stop here. Today we discuss the pre-eclampsia, in the hypertensive diseases, hepatic diseases in pregnancy. In the next, we shall discuss the case history number 4 and see how that patient is different from the our 3 case histories which we have discussed, and we will learn what is that disease, what are its clinical features, and how to manage that. Till then, take care. Khuda Hafiz. See you in the case history number 4 discussion in the next video.